Good morning, ladies and gentlemen. Distal humerus fractures. They present a significant dilemma in management of, and despite recent advances. They have a demographic bimodal presentation in high-energy younger population and in the elderly osteoporotic population. The problem is in the comminution, the osteoporotic bone, and they create a problematic situation where the intra-articular comminution creates a poor bone stock for solid fixation and limited space for fixation devices. The distal humerus is well known, comprised by two columns, medial and lateral, with the work of Driscoll in 2005, and the two columns are closing through the thigh arc, creating an intrinsic stability to the distal humerus, even in the osteoporotic bone. When we want to reproduce this stability, we have to reinforce the whole thigh arch, probably with plates and screws, as we're going to see. The AO classification gives us the classification of the comminuted areas, and the special areas we are talking about are A3, C2, C3. These are the comminuted areas that are creating the most problems in this type of fractures. Severe comminution, bone loss, and osteopenia, given satisfactory results due to inadequate fixation onto these poor structures. So the poor outcomes include mainly stiffness, secondary to prolonged immobilization, which is necessary to protect the unstable fixation, and a union at the supracondylar area, usually due to comminution and poor biology of the area. Age, functional demand, and bone quality are important aspects for decision-making in these fractures. Of course, the treatment of choice is the osteosynthesis. In the elderly, with osteoporotic and comminuted or very distal fracture patterns, in whose fixation might be taken as difficult, we could apply total elbow arthroplasty with rather good results in this age group. Preparative planning, usual X-rays, CT scan, 3D reconstruction. We have to identify single fragments, surfaces, spikes, edges, what is impacted, and just to remind you, the traction view that gives extra information through a simple X-ray as well. What we know from our work is a typical tactic based on the AO principles for reconstruction of the distal humerus as distal part of a bone in a joint. So we have to anatomically reduce the articular surface and apply a stable internal fixation. Then we have to restore the continuity with the shaft of the bone with another stable fixation with metaphysis and bone, and go for an early range of motion. If there are biologically poor areas, we have judicious use of provisional internal fixation to restore the articular block, and plus or minus bone graft, allograft, or autograft to fill the metaphyseal usually area. Implant choice. Thankfully, we have in our armamentarium medial, lateral, posterior plates, or these are pre-contour locking plates, to apply them parallelly or orthogonally, and if we are happy enough to have variable angle locking screws that are very, very helpful at the distal part. Optimal approach. The patient can be in a general anesthesia or in an auxiliary block, either prone or in a decubitus position. Approaches that you might choose, depending, of course, on the fracture configuration and the surgeon's expertise. Paratricipital, triceps split, olecranostomy, trap approach, and statistically, most of the surgeons, as you see, they choose olecranostomy, more than 50%. Technical points and objectives. Again, with Driscoll's work, who proposed two principles not far away from IO original principles. We have to maximize fixation and stability of the distal articular fragments, and then the whole fixation of the distal fragments should contribute to the stability and connect it to the diaphyseal area of the shaft. This reconstitutes the keystone concept as the keystone in a big stone arc, or if you put another word, the trochlear tie arch concept. So we have to put the keystone in between the two columns of the distal humerus in a stable fixation. O'Driscoll gave us, with a later work of 2007, principles to do that. 8 principles for screws and plates. Every screw should pass through the plate. Every screw should engage the opposite side. The number of screws in both sides, articular and diaphyseal, should be adequate for the construction. Screws should be long as possible. Each screw should engage as many articular fragments as possible, and screws should lock together by interdigitation at the tie arc, the keystone area. Plates. The plates should be compressed on the supracondylar lever for both columns, both sides, and be strong enough and stiff to resist the early rehabilitation of the patient. In all circumstances, we should be aware that we shouldn't apply soft tissue stripping on the articular fragments. How we do it? After the chosen approach, we're trying to reduce the articular fragments. We have to remember all these fragments are usually rotated through the soft tissues. We have to derotate them and fix them provisionally with K-wires. K-wires are placed as possible away of the side that the plate would take. Apply the plate, apply provisional fixation, start usually with the lateral column and the first screw, and then at the first hole, and then go to the medial plate, apply a screw at the third hole, and then etc., side by side. When we reach the fourth stage, we should apply compression. This compression starts usually from the lateral side with a screw, and then from the medial side. At least 4 locking screws are needed for the distal segment to interdigitate and keep a stable fixation in between the distal and the shaft, the distal fragment and the shaft. Plate configuration. Usually it's a double plate technique. There are rare occasions that a third plate can be put. The original work of O'Driscoll suggested parallel plates, but parallel and orthogonal plating have similar outcomes in the literature. An advice would be to put different length of plating, so you would avoid the stress rising and possible peripatetic fracture. There are multiple studies about it, clinical and biomechanical, that prove that there is no difference in between the two groups, parallel or orthogonal plating. What's happening now if we have a comminuted area, which is the metaphyseal area, the supracondylar area, and the options we have? Okay, suggestions from older types of fixation: put a strong structural bone graft. Not an option, actually. Shorten it, yes. O'Driscoll suggests shorten the proximal part of the fracture, the shaft, and shorten it in a way that can interdigitate with the distal set of fragments. So you can reshape the distal end of the shaft in a way that can, let's say, apply a nearly closed fracture area, and then fix the whole fracture in a certain way, but with the same rules. Shortening less than 1 centimeter doesn't create any effect in triceps strength, and the shortening as much as 2 centimeters is well tolerated. Regarding the way of fixing the osteosynthesis, we can shorten, but we cannot fix in rotation. We cannot change the valgus, and we can fix it in a slight anterior position, not posterior. So anteriorly shortened, do not disturb the valgus, do not disturb the rotation. Non-union. As everybody understands, the non-union might come in the supracondylar level. Literature shows non-union implant failure almost 0 to 13%, mainly due to the comminution and unsatisfactory fixation. Usually this is a high-energy trauma, might be poor bone stock if the age is older. Revision for such a non-union is technically challenging and full of risks and complications. We may need external fixation, fibular strut grafts for column reconstruction, or total elbow arthroplasty. So fracture stability is the critical determinant of the outcome. We should end our operation by feeling that the whole construction is stable enough to withstand the rehabilitation. Several methods have been used to address non-union in bone defects in chronic cases. As already mentioned, vascularized fibular grafts, autologous iliac crest, and bone grafting, allografting. The soft tissue management. We shouldn't soft tissue strip, especially from the lateral column. At all circumstances, we should retain soft tissues, especially on articular fragments. Putting the plane on top of the common extension origin or on top of the lateral collateral ligament complex might create a necrosis of the area and loss of motion. Plates should not wrap around the epicondyle. Articular surface reconstruction. We might have situations where there might be combination of distal humerus fracture with searing types of fracture. In all cases, we have two important principles to deal with it. The anterior part of the articular surface is the critical part. Of course, the posterior half is important, but not as critical as the anterior part. In any situation, stability of the articular requires the medial trochlea. If we have the lateral trochlea, we are happy. If we have the medial trochlea and the capitellum, we are happy again. So definitely medial trochlea plus minus the lateral trochlea, but if we don't have the lateral trochlea, medial trochlea, and capitellum, so we have a stability in motion. Elbow arthroplasty. The literature evidence supports use of the total arthroplasty, either primary or delayed in this situation, as a valid treatment for complex comminuted distal humeral fracture, especially in the elderly. In younger patients, every effort should be made to preserve the joint through fixation. Hemiarthroplasty. It's an alternative form of arthroplasty in active elderly patients with acute fractures. We should give paramount importance to have a stability through the fixation of collateral ligaments and choose an implant that could be convertible in the future in a total elbow arthroplasty. Ulnar nerve transposition. Two big studies, meta-analysis studies. One with almost 1,300 patients, 17 studies, no transposition needed without ulnar injury. So leave it in place. Another study, meta-analysis, almost 400 cases, is sufficient evidence for routine transposition. Only those who have preoperative ulnar nerve symptoms should be either decompressed in situ or transposed. There is no proof that the postoperative ulnar nerve neuropathy is due to greater fracture severity, iatrogenic injury during surgery, subsequent surgical scarring with the fracture healing. Nobody knows. So transposition, ulnar transposition does not have a effect on these kind of fractures. Postoperative management. We should early mobilize our case. As soon the better. The sooner the better. We should apply a night split in extended position, and we should start muscle strengthening almost in 3 months. Just remember, for at least 6 months, we'll still have improvement in range of motion in these cases. For some, even in 12 months. Complications, many, too many. Up to 48% in C-type fractures literature. The problematic contractures and elbow stiffness, non-union, malunion, hardware failure. What to remember? Challenging fractures. Although we have advances in plate design and we have very nice implants, surgical technique will improve the outcome of patient undergoing internal fixation. The procedure is challenging with a high rate of complications. Total elbow arthroplasty has been advocated as a treatment option, especially for the elderly people. And thank you very much.